Welcome to my YouTube channel. It's Sister Anniebel and it's from Zambia. If you're a returning subscriber, I said thank you so much for returning. And if you're a new subscriber, thank you so much for subscribing to this channel. And if you're just watching, you've not subscribed, I beg you to subscribe to this channel, turn on notification bells, smash the like button, and then drop comments if you have any questions for me. Today we are going to talk about gastritis. So I want you to take a pen, a paper, and write down points that you see. They are very helpful. If you are just a mother, you want to know about gastritis, please, this is the right channel and this is the right topic for you. So we are going to begin. Gastritis is an inflammation of the gastric mucosa or the lining of the stomach. So gastritis is an inflammation of the gastric mucosa or the lining of the stomach, characterized by epigastric pain, nausea, and vomiting. And then you can name others. So the pathophysiology, I'm going to read through the general pathophysiology of gastritis. So the gastric mucosa is protected from acid autodigestion by prostaglandins. So injury occurs when there is a breakdown in the protective barrier. The resulting of injury is compounded by histamine released and vagal nerve stimulations, which leads to hydrochloric acid diffusing back into the mucosa and injure the small vessels, resulting to edema, hemorrhage, and the illusion of the stomach lining. As the disease progresses, the walls and the lining of the stomach thin and atrophy decreases the functions of the parietal cells. The source of intrinsic factors is also lost, and the absorption of vitamin B12 is impaired, leading to pernicious anemia. So, with the mucosal lining of the stomach is protected by prostaglandins. So the injury occurs when there is a breakdown in that mucosal lining, which is the histamine is released, the vagal nerves stimulates to release hydrochloric acid, and hydrochloric acid seeps back to diffuse into the mucosal lining, causing the hemorrhage, causing the erosion. They can cause edema. That's what causes gastritis. So in general, that is gastritis. So we are going to talk about the types. So we have two types of gastritis. So we have acute gastritis and we have chronic gastritis. So we are going to talk about these two types of gastritis in details. So I'll start with the acute gastritis. So acute gastritis is an inflammation of gastric mucosa or submucosa with the destruction of the superficial epithelial cells. So acute gastritis is an inflammation of gastric mucosa or submucosa with the destruction of superficial epithelial cells. These conditions can last a few hours to few days. So, causes in acute gastritis. So we have thermal cause. So thermal cause is when you take hot fluid or hot food. It can cause acute gastritis. Then we have chemical cause. In chemical cause, it's when you ingest corrosive substances. Well, yes, you can have acute gastritis. Food which cause irritation, such as spiced food. So if you ingest spiced food, some people will tend to have gastritis. If you take some drugs like aspirin, you can have gastritis. If you take non-steroidal anti-inflammatory drugs, you can have gastritis, or corticosteroid drugs, you can have acute gastritis. Then you can also have bacterial cause. Yes, so under bacterial cause we can have endotoxins released from infecting bacteria such as Staphylococcus, E. coli, Salmonella, and Helicobacter pylori. So these are the bacteria that will release some chemicals that can cause acute gastritis. Then we have some conditions like uremia. Yes, uremia can cause acute gastritis. Prolonged emotion tension, like those people who are depressed and they don't want to eat, you can lead to acute gastritis. Then we have people with major veins, yes, major veins, renal diseases, peptic ulcers, surgery, all those can lead to acute gastritis. Then we have bowel reflux, yes, a backflow of bile into the stomach from the bowel tract that connects the liver and the gallbladder. You can also have it can also lead to gastritis. Then we have exposure to certain procedures such as nasogastric tube insertion or endoscopy. It can lead to acute gastritis. So having said the causes of acute gastritis, we're going to talk about the signs and symptoms of acute gastritis. So some signs and symptoms, we can have the onset of signs and symptoms like anorexia. Yes, anorexia. We can have nausea and vomiting. We can have dyspepsia. We can have epigastric pain. Excuse me. We can have water brush syndrome. We can have pernicious anemia. We can have colic diarrhea. We can have fever, which may be present. We can have hematemesis. Yeah, hematemesis. We can have melena in stew due to gastritis. Those are some of the signs and symptoms of gastritis. Then diagnosis. So diagnosis, we can do endoscopy or gastroscopy, which will show the inflamed gastric membranes. We can have full blood count, which will show low hemoglobin due to concealed bleeding, or as occult blood will be present in vomitus or blood. Then in full blood count, we can also see the increased ESR due to infection. Then we can have histological examination of biopsy specimen. Then we can have serologic testing for antibodies for Helicobacter pylori, or breath test. We can also have gastric acid analysis, which will reveal the increased hydrochloric secretion. So the treatment, we are going to, in acute phase, or if the patient is vomiting, avoid oral fluid and food when the patient is vomiting. But when the patient is not vomiting and there is signs of dehydration, oral fluid and non-irritating food should be okay. So oral fluid and non-irritating food should be reintroduced gradually according to the patient's tolerance. So if the patient was vomiting, we are going to avoid oral food and oral fluids. But if the patient stabilizes, then we are going to reintroduce those oral fluids and food gradually according to the patient's tolerance. Then if the patient is dehydrated, we are going to administer intravenous fluid. Yes, we are going to administer intravenous fluid to correct dehydration and electrolyte imbalance. So those that we are going to do. And then for drugs, we are going to give antiemetics, which is promethazine, to relieve nausea and vomiting and to avoid the cause due to corrosive. Then we are going to do anticholinergic, atropine, which is atropine, to reduce the gastric secretions and to relax the smooth muscles. Then we can also give cimetidine. Yes, cimetidine to reduce gastric secretion and hemorrhage associated to gastritis. So that's what we are going to do in acute gastritis. Now we talk about chronic gastritis. So definition for chronic gastritis: this is a chronic degeneration of the mucosa membrane of the stomach which may follow prolonged dietary indiscretion or alcohol abuse. So chronic gastritis can come as a result of degeneration of the mucosa membrane of the stomach, which will follow prolonged dietary indiscretion and alcohol abuse. So the causative or the causes for chronic gastritis, it can be Helicobacter pylori, alcohol, thyroid diseases, diabetes mellitus, radiation, repeated attacking of acute gastritis, autoimmune conditions such as pernicious anemia. Then we can also have smoking. Yes, smoking can also cause chronic gastritis. Then the signs and symptoms of chronic gastritis: we can have anorexia leading to loss of weight. Then we can have nausea and vomiting, which will be relieved after will relieve pain due to irritation of the gastric mucosa. Then we have dysplasia due to impaired gastric functions. Then we have epigastric pain, which will come as heartburn. Yes, we have a heartburn or epigastric pain due to regurgitation of the gastric contents. Then we have abdominal pain due to erosion of the gastric mucosa. We have melena. Yes, melena in stool due to gastric bleeding. Then we can have constipation, which will later followed by diarrhea due to enteritis. Then we can have slow in progress. We can have flatulence. Yes, presence of gases due to impaired mucosa function. So those are some of the signs and symptoms that we can have in chronic gastritis. So we do the diagnosis. So diagnosis, will do history taken from the patient, which will review the recurrence of acute gastritis. So you're going to ask the patient, have you had this problem before? How often do you have this problem before? Then it will guide you. And then we can have a barium meal review. A barium meal will review inflammation of the gastric mucosa. And then we can do endoscopy or gastroscopy, which will review the inflammation of the gastric mucosa. And then we can have stool for cord blood. Yeah. Then we can also have FBC, which is full blood count, which will review the raw HB due to the bleeding. Then we can have gastric acid analysis, which will review the increased hydrochloric acid or hydrochloric acid secretion in the stomach. Then treatment, this is managed by modifying the patient's diet, promote rest, reducing stress, and initiating pharmacotherapy. So advise the patient to chew thoroughly before swallowing the food. Then treat Helicobacter. Yes, so you can treat Helicobacter with the triple therapy, which is amoxicillin, Fragile, and the omeprazole. So you can give the patient amoxicillin, Fragile, and the omeprazole, which is a triple therapy. Then we can give antiemetics, promethazine or placebo. Yes. Then we can also give antacid to relieve pain, which is aluminium hydroxide, which is 200 to 400 TDS for 7 days. Or we can give antihistamine receptor blockers to help the reduction of hydrochloric acid, which is cementidine, 200 to 400 for 14 days. So that is the treatment for chronic gastritis. Now, the gastritis general management. So you aim to prevent complications, to relieve the signs and symptoms, to help in healing process, and then to reduce anxiety and to reduce pain. So those should be your aims. And then the general management, we are going to do a prophylaxis, which is environment, position, rest, observation, psychological care, hygiene, exercises, nutrition, elimination, medication, and advice on discharge. So we are going in environment. We're going to treat this patient in on near the nurse's bay for easy observation of the patient. Then a clean environment to prevent other infections. Yes, and then a free noise environment, yes, to allow the patient to rest. So position, we are going to position the patient in a very comfortable position to promote comfort, of course, to the patient. Then rest, we are going to nurse this patient in a free noise environment to promote rest of the patient. So we are going to restrict visitors to promote the rest to the patient. Observation, we are going to observe the level of pain and administer painkillers. Then we are going to do vital signs, which will act as a baseline data or to detect any abnormalities from the normal. Then psychological care, we are going to explain the disease process to the patient, to allay anxiety and to gain cooperation. Then hygiene, we are going to bath the patient, do nail care, do oral care, yes, to promote comfort of the patient. Then exercises, we are going to allow the patient to do some exercises. If the condition is much better, we allow the patient to ambulate just within the hospital premises to promote blood circulation and to promote healing. Then nutrition, we are going to call the nutritionist who is going to educate the patient about the food that is supposed to take. You know, in gastritis, you're supposed to avoid food that has a lot of spices, like fluid that has gases in it, to prevent a reoccurrence of pain and gastritis. So we'll call the nutritionist to come and advise the patient on food to take and food not to take. Then elimination, if we're going to monitor the intake of fluid and the output of urine to our patient. Then in medication, we are going to give prescribed medication to this patient to promote quick recovery. Advice on discharge, we are going to advise the patient the importance of taking prescribed drug, the importance of review dates, the importance of adherence to the drugs and adherence to what the nutritionist had said to the patient. So having done the management, we are going to do the complications. So gastritis can also cause some complications like gastric ulcer. So the patient may end up having gastric ulcer if he's not adhering to the medication and the nutrition that was given to him or her. Then they can have hemorrhage, they can have anemia, they can have obstruction, they can have perforation, yes, they can have peritonitis, and they can have cancer of the stomach. Yes, you can have cancer of the stomach. So advice on discharge, adherence to the drugs, adherence to the nutrition involvement or nutrition food that the nutritionists have told you. It's very important to prevent the occurrence of acute gastritis or chronic gastritis. So that was all about gastritis. Hope you've learned something. Hope you've enjoyed this presentation, and hope you are going to invite others. Please don't forget to subscribe. Don't forget to turn on your notification bell. Don't forget to smash the like button, and don't forget to drop comments if you have any questions from me. So from me to you, it's bye and God bless you.